This video provides an overview of diabetic ketoacidosis, covering its definition, causes, pathophysiology, symptoms, complications, diagnosis, and management. Diabetic ketoacidosis, or DKA, is an acute complication of type 1 diabetes. It is characterized by hyperglycemia, ketosis, and metabolic acidosis. The causes of DKA include missed insulin doses, infections like pneumonia or a UTI, stress from events such as an MI or surgery, and undiagnosed type 1 diabetes. The pathophysiology of DKA involves insulin deficiency, leading to hyperglycemia as the liver increases gluconeogenesis and glycogenolysis. Uncontrolled fat breakdown, or lipolysis, releases free fatty acids. The liver converts these into ketones, causing metabolic acidosis. High blood glucose leads to osmotic diuresis, resulting in severe dehydration. The loss of sodium and potassium also contributes to electrolyte imbalances. Common symptoms of DKA include polyuria, polydipsia, weight loss, nausea, vomiting, abdominal pain, weakness, and blurred vision. Signs of DKA include dehydration, hypotension, and tachycardia. You may also observe Kussmaul breathing, a fruity breath odor due to acetone, cold extremities, hypothermia, confusion, and coma. Complications of DKA include cerebral edema, especially in children, which may require mannitol. Hypokalemia can cause cardiac arrhythmias. Shock and multi-organ failure can occur if not treated promptly, along with pulmonary edema, gastroparesis, and AKI. Diagnosis involves checking blood glucose levels, serum electrolytes, ABGs, urine for ketones, ECG, and a chest X-ray. Management of DKA starts with fluid replacement, typically with 0.9% normal saline. The infusion rate is carefully managed, and fluids are switched to 5% dextrose saline when plasma glucose drops below 15 mmol. Avoid fluid overload in elderly patients. Insulin is administered intravenously using an infusion pump. The initial rate is 6 units per hour and is reduced as blood glucose levels drop. Glucose levels must be checked hourly and the infusion rate adjusted if there is no reduction in the first hour. Potassium management is critical. None is given in the first liter of IV fluids unless plasma potassium is less than 3.0 mmol/L. Infusion rates vary based on current potassium levels. Bicarbonate is reserved for severely acidotic patients with a pH less than 7.0. Sodium bicarbonate is infused over 30 minutes in a large vein with simultaneous potassium administration. Additional procedures may include catheterization if no urine is passed after 3 hours, or a nasogastric tube for unconscious or severely vomiting patients. A central venous line may be needed if the cardiovascular system is compromised. Other interventions include plasma expanders for low blood pressure, antibiotics for suspected infection, and ECG monitoring in severe cases. Thank you for watching this video on diabetic ketoacidosis.